Surgical protocol for 4.2 mm diameter implant with installation. Surgical protocol of the installation of BL3 implants. The point of dental implantation is in dental restoration. To make it more natural, implant companies have invented tapered implant shape of which is similar to the shape of tooth root. In order to make the integration more natural, shape of prepared implant site must match with the implant shape in the same manner as shape of the alveolar socket matches with the tooth root. It is necessary to follow surgical protocol completely. That is why we use sequential drilling of the site with drills. For further information, please continue reading. Let's try to perform implantation of polyurethane model. We should follow some rules in order to do that. First, it's compliance with drilling sequence to avoid overheating or breaking of alveolar crest bone. Implantation begins with marking the place of prospective drilling. Marking burr shall be installed in surgical tip. Acceptable drilling rotation rate is from 200 to 1200. The most appropriate rate is 500. The less diameter of the burr, the higher rotation rate is allowed. The marking burr marks the place of further drilling on the alveolar crest, so that next pilot drill will not come off the place of drilling and also to pass the cortical layer. There is laser marking on the pilot drill, also there are stoppers for it. Before drilling, it is necessary to define length and diameter of installable implant. We have chosen the implant which is 11.5 mm long and 4.2 mm in diameter. We are going to drill to this depth according to marking dimensions. However, experienced surgeons claim that it is important to drill deeper so that when inserting the implant, we would be able to set it lower than the level of compact substance. So we are going to drill 0.5, 1 mm deeper than the length of implant. We choose stopper. Install it until we hear the click. Insert it in surgical tip. To avoid overheating, it is important to perform back and forth motions during drilling. In this case, normal saline is able to wash the whole drill surface, cooling it and washing away bone remnants. At this moment, saline is absent because we are applying a model. Abiding by surgical protocol, we take a drill of next diameter. Also, we install stopper on it until we hear click. Drill is inserted with back and forth motions. However, it is recommended to reduce rotation rate by 150 to 100 units with every subsequent diameter. It is important that pressure on the drill should be minimal to avoid overheating of the bone. This set of drills is very good because they have diamond-like coating and their cutting ability is very high. That is why there is no need to press on the drill while passing compact substance. Let us moving on to the next drill. I draw your attention that we have chosen 4.2 diameter implant, so we stop at drill number 6. There is a hint under it. You could see the drill is dragged down by itself during the rotation. Stoppers are absent after the drill 2.8 mm. You are able to observe the depth of drilling using millimeter cuts. Also, there could be a ruler at the surgeon's hand which allows controlling the length of the drill. As I have said previously, it is better to drill 0.5 1 mm deeper than the length of the implant. If bones allow doing that at that certain area. Next drill's diameter is 3.5 mm. Having controlled the depth, we perform drilling, decreasing rotation by 150 units. And the last drill is number 6, which fits the implant 4.2 mm in diameter. If we had chosen wider implant, we would have used wider drills. We decrease rotations, perform drilling. Implant site is prepared. We take sterile implant, which is installed at implant driver. Open near oral cavity, not touching surrounding tissues and biological liquids except blood. Insert into prepared socket. Rotate with fingers until primary fixation of the implant inside. At that matching of the implant, axis must be controlled manually. After obtaining the fixation of the implant in the bone, we should take off implant driver, which was installed on the implant, and take implant driver for the ratchet wrench to insert implant fully into the bone. As this implant has wide platform, wide elongated implant driver must be taken. We install it in implant. To insert implant properly into the bone without residual compression, it is better to insert implant using torque wrench. There is a scale on the torque wrench. According to accepted standards, implant should be installed with pressure not exceeding 40-60 Newton. You could be bigger value for the short period of time, but it is not crucial. It is important to perform back and forth motion and at the end to leave compression not exceeding 40 Newton. Let's insert implant. We put the ratchet wrench on the implant driver. At that, index finger should be always placed on implant driver performing pressure and controlling axis of insertion. If you don't press the implant driver, implant will tend to pick bone from this side, which can interfere primary stabilization. Implant must be inserted slowly, better with breaks, so that bone will be able to expand and not to get more compression under overheat due to high friction force. Also, implant can be inserted in the bone with surgical tip using implant driver for machinery insertion. Now, when equator of the implant is in compact substance level, you receive maximum resistance. How to eliminate it? By using back and forth motions. During this, there is allocation of remnants inside the site. It is not necessary to take off or rotate the wrench. We change the direction of wrench's work. Perform back motion until the relief. Change direction of wrench's work again and screw it. Such motions could be performed many times. We advise not to rush. If you get high pressure with thick compact layer, you can take off implant fully, put it into sterile vial using implant driver and work out compact substance with countersink so you could make decompression in it. I draw your attention to the fact that we work with polyurethane model, which is dry and there is no way to compensate the load in it. We can compensate it by using back and forth motions on the real bone. It is much more difficult to perform that on this model. It is necessary to insert implant 1.5 mm lower than the cortical level to avoid denudation of implant neck and recession. We have screwed implant at 40 Newton. Take out implant driver. Implant has been installed correctly, which is lower than the compact bar level.